is Dr. Obaid Rahman, and along with my co-residents, Drs. Purnima Kabir, Omar Dominguez, and our attending physician, Dr. Ganesh Eswat, it's our pleasure to present our case report of an acute esophageal necrosis as a finding of diabetic ketoacidosis. AEN, also known as black esophagus, is a severe complication of esophagitis and is characterized by necrosis in the distal segment of the gastroesophageal junction. AEN can also manifest in critically ill patients as an uncommon complication of DKA. Our case study focuses on a 49-year-old male with a past medical history of diabetes, hyperlipidemia, COPD, coronary artery disease, and osteomyelitis who had presented to the ED with altered mental status and 6 days of recurrent hematemesis. He had a similar presentation in 2016, and an EGD at that time had revealed grade 4 esophagitis, and he had been non-compliant with his PPI therapy. Otherwise, his social history is significant for a 30-pack-year smoking history with no alcohol or drug use. On admissions, his vitals were notable for blood pressure 98/56, heart rate 109, respiratory rate 30, 98% O2 sat on room air. His physical exam showed a soft, non-distended abdomen with generalized abdominal tenderness to deep palpation and no clear localization of pain. No other pertinent physical exam findings were noted. Lab data showed hemoglobin of 8.5, bicarbonate 5, anion gap 17, serum glucose 486, pH 7.1, and an A1C of 14.9%. CT abdomen pelvis with contrast revealed nonspecific thickening of the distal esophagus. Patient was admitted to the ICU and started on DKA protocol with aggressive IV fluids and an insulin drip. He was also started on IV pantoprazole, ondansetron, and TPN. His hemoglobin had trended down to 6.7 the day after admission, and he was given 2 units of PRBCs, after which his hemoglobin trended up to 8.7. Once he was hemodynamically stable, an EGD was performed, as seen in Figure 1, which revealed abnormal black necrotic mucosa along the entire esophagus up to the GE junction. Esophageal biopsies showed necroinflammatory debris likely secondary to AEN-associated injury to the mucosa. No further episodes of hematemesis were observed, and the patient was discharged 11 days after admission. Follow-up EGD 8 months later showed a normal esophagus without any evidence of esophagitis or necrosis. So today we want to talk about AEN and its association with DKA. The overall estimated incidence of AEN is low. However, conditions such as uncontrolled diabetes, cardiovascular, renal or liver disease, malignancy, malnutrition, and alcohol abuse may have an increased risk of developing AEN. The etiology is relatively unclear but has been associated with ischemic esophageal injury, backflow of gastric acid, and or a weakened protective immune response. The distal third of the esophagus is frequently affected by AEN, possibly due to having relatively limited vascular supply when compared to the proximal and middle thirds of the esophagus. Presentation typically occurs in males between the age of 60 to 70 years old who present with coffee ground emesis, melena, abdominal pain, nausea, vomiting, low-grade fever, and or syncope. Common lab findings include leukocytosis, renal insufficiency, or anemia. Complications generally include esophageal perforation deteriorating to mediastinitis, mediastinal abscess, or empyema. Esophageal strictures can also occur, resulting in stenosis, and cases have reported superimposed bacterial, viral, or fungal infections as well. Prognostic factors that have been associated with high mortality are tachycardia, anemia, sepsis, and hypoalbuminemia. Association with DKA is unclear. However, recent literature shows that severe volume depletion or GERD in patients with DKA shows a higher incidence of precipitation to AEN. Management of AEN is primarily conservative. Mainstay of treatment is bowel rest, hemodynamic resuscitation with IV hydration, IV PPI, and surveillance EGD is crucial to assess for regression of AEN. This concludes our presentation on AEN as a rare finding in a DKA patient and can hopefully guide in management of patients with similar presentation.